Okay, what do you want to talk about?
So for a long time, we've talked about doing like little sort of discussions or talks about topics that patients ask us about all the time. So I thought like a first crack at it, we could talk about trochleoplasty.
Okay, so trochleoplasty is a little bit of an obscure part of patellofemoral surgery. Um,
But it somehow like gets a lot of press. Like if we're at a national meeting talking about knee surgery or specifically patellofemoral surgery, somebody always wants to talk about trochleoplasty. And what trochleoplasty means is basically taking the front of your thigh bone and making a groove in patients who were born such that they really don't have a groove.
Yeah, so everyone looks different, obviously, and that's true for the shapes of our knee joints. So for the most part, the front part, as you said, of the thigh bone, so kind of behind the kneecap, that area is called the trochlear groove, which implies that there's a groove so that the kneecap can run into that groove almost like on train tracks, which makes it really stable. But some people are born with what's called trochlear dysplasia. Dysplasia just means different shape. And instead of there being a groove, it's flat, or in some people it's even convex. So then you have the kneecap trying to balance. Some people say it's almost like you try and balance two basketballs on top of each other. It's not very stable. So those patients oftentimes have a lot of issues with kneecap instability.
And they're also more likely to get arthritis. And so as we've been trying to sort this out for the past 30 plus years, but at least for us, the last 20 years, what we've generally done is we've tried to realign the knee in such a way that we kind of keep the kneecap sort of centered over the trochlear, the front of the thigh bone. And I don't think to either of us it ever made a whole lot of sense to make a new groove because bones or joints form in relation to each other. So if you suddenly make a groove on the front of the thigh bone, but the kneecap doesn't fit inside, like I think we kind of worried about those forces not being so natural or that not being so great.
Right. So, in many dysplastic patients, it's not just only the trochlea that instead of being concave, so shaped like a groove, but the kneecap is shaped like a triangle, so it kind of fits. So you have what's called a congruent joint. And in someone who has a dysplastic trochlea, where it's flat, oftentimes the kneecap is flat. So you have flat on flat, which isn't particularly stable, but at least it's congruent, so the forces are distributed. And what you had just mentioned, if you change the shape through what's called a trochleoplasty, so a trochlear deepening osteotomy, so you make something that's flat and you kind of squish it down to make it into that triangle, but then you still have a flat patella that somehow needs to fit in there. And we always had a sense that may not be the best long-term. Short-term, it does stabilize the kneecap, but long-term, we worry about something not being congruent, leading to high rates of arthritis.
So recently an article came out, which I think both of us were very interested in. It was actually one of your former research fellows who was back in Switzerland, published a paper just looking at how these patients do long-term. Because, while I care how a patient looks at 6 months and a year, what we really want to know is how people look in 2 years and at 5 years and in 10 years, because these are young patients. Yeah. So if you're 16, you want to hopefully be good when you're 26 and 36. And so they basically had two groups in this study. They basically looked at patients where they did the things we normally do to realign and stabilize the knee, osteotomy, MPFL.
So anything but a trochleoplasty in one group.
And then the other group
was trochleoplasty. And then they looked back at them and they looked at sort of the symptomatic outcomes, like, are you stable? Do you hurt? And that was pretty similar between the two groups. But what looked really different, and that sort of vindicates a little bit the concern that we had for a long time, is for the anything but a trochleoplastic group, their rates of having cartilage damage or arthritis were pretty low, less than 10%. So more than 90% of patients that follow up, the cartilage still look pretty good, which is what you're hoping for.
But in the group that had a trochleoplasty, the rates of arthritis were much, much higher. And this wasn't even 20-year follow-up. I think their follow-up average was about 3 years.
Right.
And so they were already seeing significant arthritic changes in the group that underwent trochleoplasty.
And it depends on how you define arthritis. So it's not that everyone in that group had the type of arthritis that's called bone-on-bone arthritis, where all the cartilage is gone and they needed a complete knee replacement. They just had cartilage defect, so kind of potholes. That's a little video bomb. They had developed cartilage defects that were pretty significant that the other group just didn't have. So were they on the cusp of needing a knee replacement? No, but again, we're talking about very young patients. And if you see cartilage defects like that in someone in their 20s, that doesn't bode well for when they're in their 40s. And you do an incredible number of patellofemoral replacements, and your patients are pretty young.
Yeah, my average age is 53, but some of those patients are 33 and some of those patients are 73. So it's a range, but generally this is not these patients are not elderly. Their goals are to do really active things, and their dog being part of this. So I think this is going to wrap up our discussion of trochleoplasty.
Well, I think we should maybe have sort of one punch takeaway message at the end, because neither one of us is generally very dogmatic. So this is not a message that trochleoplasty is evil, should never be done. There is definitely, we've said that for a long time, there's definitely a role for it. Even if the study shows that there's a high risk of arthritis in these patients, it may still beat the alternative of having a knee that's completely unstable and the kneecap pops out all the time.
That being said, the vast majority of patients can be stabilized without. And these patients, even those patients who had the trochleoplasty, many of them also had an MPFL, and some of them even also had an osteotomy. So it wasn't that they got one or the other, it's they got everything.
Yeah. Well, so I think that the gist should just be like anything else you do, carefully look at the patient, really make sure that that's what they need, because there are kind of less morbid things we can do to stabilize the patella. And yes, there are some people who have this extreme dysplasia, the kind of trying to balance a basketball on top of a basketball, that you really have a hard time stabilizing in a different way. And if you need a trochleoplasty because all else has failed, then that may be the important thing. But sometimes at these conferences that you had mentioned, you get the sense that, oh, everyone needs to do trochleoplasties for everything. And I think that's kind of what our message is against.
Great.
Good? Well, thanks very much. Bye-bye.